thank you very much to Betsy, Mike, and the organizers for this opportunity. It's going to be a tough act following Michelle, but also I will bring in some different perspectives, really, even though I myself also came from the AIDS-TB community and share with him those wonderful narrative of the last decade and the transformation of the global health space, which has attracted so much attention, support, leadership, and young interest as well. But we are doing something new, and in a way, many of you are already doing it because health systems has always been part of the country experience, but in the global health space, it has not. And what I would like to do today is talk about this as the new challenge for global health in a way, compared to the importance and support that many of the priority disease programs have enjoyed. Health system has been really neglected and orphaned. So we'll do that, building on the success of those programs, not at the expense. And one point that I think Michelle mentioned is the fact that among the many shifts in paradigms that AIDS brought about, and something Miriam, my colleague here, likes to emphasize, that there's been a change in the way public health was about point of service interventions to really a chronic care model. And that in itself has given great impetus to the need for health systems. I must say, sorry, where am I here? I must say that the science is still young. And so a lot of the things I will mention is really begin to put together some pieces of evidence to go beyond the contextual exceptionalism that, although reasonable, has plagued as a problem health systems. It's always so local, so contextual that we cannot see as a whole, and we need to, as science can do, and use those principles then to guide our implementation, our advocacy, and so on. But we will need more research, so I hope that I will be, as Michelle said, saying, justifying the need for more research, and that many of you will be helping us answer some of those questions going forward. I may not have time to leave time for questions and answers to describe what we are doing specifically, but I think it will become obvious from the principles that I hope to articulate. World health used to be known as tropical medicine, and there was sort of a romantic period of colonial arrangement, not so romantic for the colonies, but pioneers' efforts, the missions, experts in the north coming to eradicate mosquitoes, the early faith on vaccines, all quite linked to colonial linkages, the French with Francophone Africa, the British with their colonies, the US in Latin America, and so on. But it was nonetheless also the beginning of a community, of an effort, of a period where science and technology could be leveraged to do better. Clearly the motivations of most of the people involved were the right ones, but the envelopes, the political envelopes in which this happened were clearly larger than the actual actors within the space. This change, particularly in Africa and Asia, given Latin America had independence early on, with the end of European colonialism, and we became international health. Now, you have now 70 or 80 new countries, new nations, new independent member states with voting rights in the United Nations, in the World Health Assemblies, reasserting their sovereignty and also their own sense of pride and destiny. And that changed everything. It changed the dynamics of the work, it changed the dynamics of the role of the countries. And Ghana, of course, starting the wave over 50 years ago. But it was also taking place in the context of the Cold War, and there was this divide in the Cold War, politically, economically, conceptually, and it was also a time, because of that, of international solidarity. There was war, but there was also solidarity, and health was a political balloon. People will play with health, and if you can read the deliberations in the US Congress about how important politically it was to do health, because the Soviets seems to have a better hand at it, because in this era of international health, it was about health. It was not medicine, tropical medicine, international health. Health was to be construed socially, it was community-based. This was the time where primary health care for all and the Alma-Ata conference could take place. And it was a tricky period, and the leadership of WHO, Halder Mahler, was very careful in walking this tight line between in the Cold War forces Indeed, the United States was on its knees in the 70s, if you recall, with a similar economic crisis, oil prices spiking, the Watergate scandal, the Vietnam mess. It was a bad time. So the Soviets were gaining an upper hand on the PR of the times. And it was in that context that the Alma-Ata conference takes place. And Mahler wanted the conference to take place in a non-aligned country. He didn't want to mess up with the politics of the Cold War. And he thought of Egypt. And yet Egypt was just signing up the Camp David agreements, which pretty much turned Egypt into a pariah in the Muslim community and the Arab world. So nobody will show up, even in the rest of the WHO work in their offices for a couple of years. So that was out. And the Soviets, Russia kept insisting in paying for the whole conference. It was a Soviet republic, and so that was so. And in 78, this happened. As it happened, the United States had no delegation to Alma-Ata, although Senator Kennedy was there, sitting next to Mahler in his personal capacity. And, but the US was not there officially. The Chinese did not go either, and the Chinese had as many credentials as the Soviets in socialism and primary care with the barefoot doctors. They were just in a hot war in the Northeast with Russia and about to invade Vietnam, which was a Soviet-supported country. So it was a difficult period. The Chinese not showing up also was a problem. So there were many politics on what otherwise is a pristine beacon of public health, Alma-Ata and primary health and health for all. And that was a problem. It remains a beacon for many of us in public health, but it was already at birth politicized. And that political dimensions took a price with the end of the Cold War when we became global health. With the end of the Cold War, Reagan was now the high priest of the period, and Reagan froze the budget of WHO and remained frozen until just the last administration. So for over 20 years, the core budget of WHO was not to increase, leveraging the high proportion of the budget the US had. And well, that's how it works out. And it was in part Alma-Ata, in part the alignment with the Cold War era and so on. Many other things, obviously, as well involved. But it was the case. And it was a sad period. There was almost like a hangover first in the 80s. That was difficult, very difficult for the community, for global health in general. And yet, global health began to brew there because other forces were at play with the end of the Cold War. Globalization, trade, markets, ITs, NGOs. It was the time where markets and NGOs could supply all of the services required. Who needed government was the question at the time. And governments were supposed to shrink forever. And the World Bank reforms at the time pretty much made that also effective. And it was a difficult period again in that sense, but things began to happen in a different way. And you have now new philanthropies, new funds, and many public-private partnerships. And the Rockefeller Foundation was very much involved in setting up many of those partnerships. First around R&D, and Bob is here from the International AIDS Vaccine Initiative, TB drug development, dengue vaccine, new medicines for malaria. There was a new model. WHO was going crazy at the beginning, not knowing what was happening, what to do, but it was a new world. The world had changed. And all these public-private partnerships were now happening for good reason. And, but also in the political sense, they could not have happened, I believe, in the 1970s, in the middle of the Cold War, when public and private were polarized. They were possible in this new globalized era. And likewise, I believe Alma-Ata may not have been possible in the 90s. So the political economy matters, and things do change. And I believe we are now heading for another big change. And this is just a hypothesis, a speculation for us all. I believe the meltdown of the market last year changes things dramatically. And I believe in markets, I believe in profits. I'm not against that. The Rockefeller Foundation was based on both. But I believe this will change again the space in which we do our work. And there's sort of a pendulum, right? Tropical medicine was technical, more vertical, priorities, eradication. Then international health was more horizontal. I don't believe in horizontals or verticals. I believe in the whole, but the tone was clear. Then global health became again priority disease, technology solutions, and expertise, and so on. I believe this is changing again. And first, the financial crisis itself unlike the 70s and 80s where they were inflationary and calling for fiscal disciplines, tightening of social spending and all of that. This one actually has frozen the financial flows and credit markets so that this type of crisis has been calling for a stimulus, and we've seen a lot of stimulus. So it's a different crisis in that sense, but it's also a very profound crisis, obviously, and is not one that simply affects budgets or concerns for subsequent funding. It is a crisis that has the potential to catalyze, paradoxically, the political will to transform social protection, health systems in particular. And most of the examples of universal health coverage in the world happen not out of rational advocacy, but out of crisis. And it was crisis that triggered the opportunity, and the things then happened. But more profoundly, I believe this is going to change the political economy too, and that the pendulum will shift, I believe, back to national governments. And that will change how we work and what we can do and what we cannot do that easily. And this is what I think we'll see in the next 5 years. And in another 5 or 10, the markets will be up and running again, and everything will begin to move back in the other direction. But I believe the pendulum of history will have this taste. And even the United States, where until recently, the federal government was supposed to shrink in the social space. Cities and states were supposed to do it. Who needed the federal government? And of course now cities and governments are on their knees and really depending on the national government. This is not only happening in the United States, it's actually happening around the world. And so the strengthening of the hand of governments means a lot for the type of work we may do in the next decade. This past decade, though, was phenomenal. As Michelle pointed out, the spending went from barely $3 billion in global health, nearly now 17 billion, and so hopefully reaching 20 billion in the future. So a lot of money has gone into health, quite a success story in so many ways. And yet, as you also know, the challenge has not totally gone away. There's been a lot of success, and we have to acknowledge the improvements in infant mortality, in AIDS, tuberculosis, infection rates probably going down now for the first time in history. So many good things actually happening. But there are still nearly 10 million kids dying every year, mostly from things for which we have solutions. And or over 500,000 women dying because they're giving birth. And so these are things for which the health system as a whole is an indicator of dysfunctionality, and for which select interventions might be helpful, and there's still plenty of room there. But we certainly should be also thinking of the whole. It is the case that MDGs will not be achieved unless we address health systems as a whole. And this map also shows, of course, where those kids are dying, mainly the poor countries, Sub-Saharan Africa and Southeast Asia. It is important, though, because the previous slides, most of that money, actually 80% of the US funding internationally in health is for HIV. And HIV is responsible for only 3% of these deaths. So we need more for the priority programs, but we also need more for the rest. And how to get that balance is, of course, a challenge that the countries themselves live every day. The challenge that we see is at the core is the health systems, but they're more general, as I heard in the previous questions and answer session. Access, how do we have access to all of the other conditions people come with complaints on diarrhea, pneumonia, a rash, fevers. Quality, which has been considered a luxury. We don't know even how to measure it well in a system today in Africa, but also involves safety, patient safety, mistakes, and things that we need to pay attention. Dignity. I mean, a country may control an AIDS epidemic by locking up all of the people at risk, and that's not necessarily the best way, really, in today's world. And affordability. There's clearly one of the issues that moved us, and is the money in the health system, and we'll talk about that. Clearly, there's a high out-of-pocket expenditures, impoverishing catastrophic expenses, and no health insurance, really, to speak of. When Obama and Hillary were debating in the primaries about how they will remain committed to fighting AIDS and other diseases in Africa, I was telling my wife, maybe in the next election, they will talk about how every human being should have health coverage, health insurance. I mean, why only 5% of Africans should have health insurance, health coverage. We worry about the 15% of Americans without it, but we don't even realize that 95% of the people in Africa do not have it. And what does this mean? It's not about necessarily just giving more money to them buy insurance for all of the people in Africa. It is just the result of what I believe is just bad stewardship of the system. In this slide from the bank, as you can see, low-income countries, most of their spending is private, out of pocket. A little bit of insurance, and then the governments, including a lot of the ODA that we spoke of before, buried in the public budgets. That means that the health spending in low-income countries is the people's own money. It's not foreign aid. It's the people's own money. And it's being spent in the worst form possible. This is inefficient and regressive. The poor are hit the worst. And so 150 million people every year end up spending nearly half of their annual income in health. In health, we doctors don't like to harm. We think first do not harm. But in providing services, we're actually hurting people. 25 million families who are no longer poor every year become poor because of health expenditure. In this country, 62% of the bankruptcies before this crisis, this housing crisis, 62% is due to health bills. And so clearly, as countries develop, you can see how things become more rational. It's not so much that it has to be a government-driven system, but the financing and the stewardship, clearly the government matters. And this is simply how it happens in the world today. And as that's happened, though, I must point out that the service provision become more private. That is, the poor countries have mostly out-of-pocket private financing and some government service provision. But that changes, and the private sector becomes more and more involved in the provision, just as governments become more and more involved in the financing. Lots of things here, and this slide also from the bank showing how people pay for things. And most of them spend their incomes, as I said before, or sell their, borrow from family, or sell the house, or sell the cow. It's a mess. It's quite bad, and it's happening every year. Now here, and this may be a bit of a stretch, but I would like to position early on the importance of universal coverage as the new frontier for global health. This is the first map, actually, I've seen on universal health coverage, and it is based on data from the International Labour Organization's report on social protection for health from last year, which uses a definition of universal coverage that allows the United States and South Africa to appear as if they had universal coverage in the sense that many of us may share. And that is, it is the case that in this country, if you're sick, you can go to the emergency room and by law you will be taken care of. But we know that that's not how it works, right? They start sending you bills and there's no follow-up. So, but constitutionally you have the right to health, and in that formal definition, the US and South Africa may look all right. But importantly, these maps, which I believe universal health coverage is the right thing, both economically, and we'll speak to that, but also as a human right. It's also feasible, and because nearly 50 countries already have universal health coverage, which again is both about reorganizing service provision and access, but also the financial protection that a whole system can organize. And it is beginning to happen, in the world. It's also clear, of course, that it is precisely in Africa and Southeast Asia, where all of those children were dying, that we don't even know whether there's coverage. We cannot even tell today. So, and yet at the same time, there are a few countries already moving. In Latin America, there is an old tradition of social protection, and our colleagues from Mexico here, where I am from, by the way, may speak more about the experience on progress to universal coverage in Mexico. Thailand has been an example of providing universal health coverage in a country that is not rich. And there are many other examples, and we hope to talk more from our colleagues from Ghana and Rwanda that have already moved into the path of universal coverage, challenging as it is. But believe me, it is the right thing, as I will show also in a second. If we can follow the money, we can find a few things. First, that health spending money on health offers many insights. Some of them are actually counterintuitive, and I would like to provoke you with some of those data and some speculation. Clearly, the Commission on Macroeconomics and Health in 2000 in WHO made clear the need to put more money in health. And we will try to make the case here that there's more to it than that. We also believe health financing is the control knob of the health system that policymakers can use. And so it's important that we pay attention to that. And it's also crucial to really address the incentive structures that guarantees access, risk protection, and so on. Now, some people have read the book, obviously. But I mean, I am not an economist. I'm a physician and an epidemiologist and so on. But nonetheless, many of our colleagues share some views that there's somehow a right level of health spending in which poor countries don't have enough, and we need to help just reach that basic right level. And the rich countries, like the United States, are spending just too much, and we need to rein in cost. And so we have a normative sense of some middle about right amount of spending. We also think that with modern cost-effective interventions happening, progressively we should wipe out disease. And in fact, burden of disease is coming down all over the world. And even the chronic diseases in the United States, cancer, stroke, cardiovascular disease is coming down. And so we will think that as people grow healthier, age-adjusted health spending should be declining. But none of this holds, as you may know. First, in this slide, which plots GDP against childhood mortality, a slide that many of you are familiar with, shows the obvious that richer countries have less mortality among their kids. But there are a couple of interesting things here, right? So poor people do worse. That's the sad reality today. But importantly, the correlation of these two parameters is very, very middle of the road, 58%. And so there's a lot of variation here. And GDP already is highly correlated and accounts for water and sanitation, fertility rates, literacy rates. And so why do countries in the same region with the same HIV levels do so differently? What is it that they're doing differently? With the same money, they are delivering much better health. A concept of good health at low cost that 25 years ago, the Rockefeller studied and showed that countries like Cuba, Costa Rica, Kerala, Sri Lanka, China were doing quite well despite very low amount of health spending. And today we have a lot more data, more systematic data, and we are actually revisiting the good health at low cost studies. And there are new good performers, whether it's Vietnam, Eritrea, countries that can do well. I mean, China has moved out of because they have more money now than they used to in these quadrants. But we're now studying why. What is it that those health systems do differently that leads to better outcomes? 5, 10-fold outcomes with the same money. It's certainly worth learning more about that, and I hope that many of you will help us study. And it's also clear that even as you keep spending more and more and more, you don't do so much after that. So that, money matters, but it's not all about money. And as Professor Ramalingaswamy in India used to say, yes, we need more money for health, but we also need more health for the money. I think Julio probably always cites that line if he was here before. But we don't know how to do this, and those are the tough questions you were asking, many tough questions. What do you do in an economy that is informal? There's no tax base to reorganize financing. How do you do it when you have weak capacity to manage the private sector, which has been considered outside of your government system for too long, and even though it's 50 to 80% of the sector as a whole? How do you expand insurance to the rural, poor, distal areas? These are all the real challenges that some of you who are already engaged in this space are probably facing, and you can share a lot more. And again, these questions require analysis and learning, but also political leadership. Clearly, challenges are compulsion. Everybody has to be in the pool. Cross-subsidization, the rich to the poor, the healthy to the sick. and some rationing. Not everything will be covered in any health system. And so these are going to be political challenges for every society as we really grapple with health. Now, in this slide, in which GDP and total health spending are plotted, for the first time this decade we have data on most countries. For most of the last half century, we only have data on OECD countries. But now we can look at all of the countries around the world and find similar things that we have learned in OECD countries before, but they haven't percolated the minds of our global health community yet. This slide shows, of course, a strong correlation between GDP and health spending. That is, rich countries spend more in health. And that is so obvious, so commonsensical, so self-evident, that it has obscured two other parameters in this plot. The first is the correlation of these two parameters. 95% correlations are very hard to find in the real world, as you know, if those who do research, especially in the social space. Such high correlation means that we need nothing else, really. We don't need any other explanatory variable, at least. If you give me the GDP of a country, we can tell you how much the country spends in health, in total. And it also means, at least from this ecological cross-sectional data set, that there's little room for policy maneuvering. That is, that the idea that poor countries can increase their spending or the rich countries can decrease their spending and sort of tilt the line doesn't seem to be the case. The data suggests that there is a deterministic path, which the economists in the OECD countries since the 70s have called the first law of health economics. And there's no good reason, really. Well, there are some reasons, but for this tight correlation, it's still almost mystical. And so it deserves a lot of attention because it has lots of implications for each of you and our work. And importantly, when you add to this regression the proportion of the total spending that is public, which, as I said, in Africa is 50%, in Asia is 20%, it doesn't matter. It adds nothing to the regression. That is, if countries, and this data has been analyzed by Jacques Van de Gaag, who was the bank and Dean of Economics at Amsterdam University, if a government was to increase public spending, private spending out of pocket will decrease, and the total will still fall on the line. If the governments do the opposite and try to decrease health spending by decreasing the public budget, the opposite happens, and the total falls on the line. It's really amazing, because people out-of-pocket expenditures are so independent, random almost, and how, when you go back and do household surveys a year later and ask how much people spend, how does this aggregate falls, guided by an invisible hand, on the line? And this applies to countries who may have universal health systems like Canada or the UK, or countries in which the financing is private, 83%, like India or Vietnam, and they fall on the line. It applies also to Eritrea, one of the countries with the highest proportion of their public budgets that goes into defense. They also fall on the line. And so does Costa Rica, with no army. And we always thought, if that government was not buying that submarine, we could be buying so many much more vaccines. Well, the data doesn't seem to back that up. And again, this is just ecologic cross-sectional data. We need to do a lot more research. More sensitively, perhaps, is the second point, and Michelle is gone, so I can make the point here. But it's actually, more than a point, it's really a question for all of us. It's just too important a question. Michelle just said that there's no evidence that spending in AIDS crowds out spending. And to me, that is the problem. How come we spend $20 billion a year and we don't know if we are crowding out spending in poor countries? Actually, the preliminary analysis that we have done on this, that Jack has done on this, again, the data is thinner here, okay? First, because as you know, ODA accounts for just barely 5% of the low and middle income countries' health spending, so it's a small proportion compared to public, which is 50% of the spending. So smaller data, the data is probably more difficult. It is the case that a third of the ADAs hangs out international consultants, another third the Minister of Finance uses for foreign reserves, and only a third actually reaches the sector on the ground. But still, the analysis that Jacques has done, and he might try to publish, shows that crowding out seems to be at play. That is, that the health spending is a fungible space. if a country is spending $100 million in health, not only the public and private components matter, as I said before, little, but if you were to add another $20 million out of your philanthropic heart, you will expect 120. But that should show up here. And we have a few things, but in North Korea, if people are familiar with the Gapminder, we have now plotted this data into Gapminder so you can see the flow over time. And North Korea that goes crazy, so I'm sure maybe that data is not a very reliable one. But it's clear that the data suggests that the money pushes out spending. And if you are almost 50% of the spending is for HIV, and only 3% of the population have HIV, it's okay to get money for HIV, but if actually it's pushing out spending on other basic things through this mystical, invisible hand that deserves all of our research attention, then we have a problem, a big problem. And it's something that lack of evidence of the problem is not evidence of its absence, and it's something that requires a lot more attention. And I think Miriam, who has been looking at this, and Jack will be in the International Conference in Cape Town, and there will be a session just on this issue. And next year in Vienna for the major International Conference, there will be a whole parallel track now on health systems, health policy, health economics. These are two important questions to simply not answer them. Now, this is the same data. I'm cheating a little bit here because I made this into a log scale that, of course, curves the line. But it's actually honest because the point I'm trying to make is true. That is, the increase in health spending with GDP that the data suggests here is not a one-to-one relationship. It's actually a 1.1 to 1.2 log relationship. That is, for every 10% increase in GDP, health spending grows 11, 12% compounded. And so this is what's been happening around us everywhere. We've been talking a lot about it in the United States, and all of the other countries who have lower GDPs have always been sort of behind, so they're always compared to the United States being low. But the fact is, health spending is growing fast. It's not because of Abuja Declaration commitments. It's not because of the ODAs. It's the country's own money growing as their economies develop in the last 20 years. Quite a dramatic transformation that we are calling the economic transition of health. And it's not subject to policy, really. It's not you cannot increase it or decrease it easily. It's almost a deterministic path. And more understanding of that is, again, an area that deserves more research and that we are very much interested in studying and supporting. So this is the reality. And the US still is out of whack. And so in many of the oil countries seem to be spending less. But on the whole, everybody seems to be on the line. I said that R squared is 95%. So quite an incredible correlation. And the same thing is in the poorer countries where you come down the line. So this is quite dramatic. It's out there. It's happening, but we don't get to see it. We've been busy fighting HTV malaria. And yet this is so important right now, especially if we're going to have a rational system that provides access and quality and affordability. Now, this is a slide that shows GDP growth. As you can see, the GDP in the world was relatively fat for most of the history, even though the British were in the Industrial Revolution. But for the world, it was a tiny bit compared to the fact that China and India were not moving and so on. But it's after World War II that GDP takes off. The United States was leading the charge, then the Europeans in the 60s, then the Japanese in the 70s. And as you know now, everybody's been growing despite this particular year of recessions. Growth is been really taking place dramatically. I haven't been able, but maybe we should. You have to now put here total health spending growing 1.1, 1.2 log compound on the back of that growth in GDP. So the world is spending today nearly $6 trillion in health. And a lot of that money is American dollars, of course, where it's already eating 17, 18% of the GDP. But health spending is growing. This is the US, and we've been seeing it and complaining and trying to bring it down. We haven't been very successful here. Now, China. In the last 25 years, China health spending grew not twice, not 10 times, not 20 times, it grew 50 times. And the government was trying to increase health spending. In the top is the government spending. But the GDP growth of China was calling for more. It was like this God who was calling for more spending because the GDP was growing. So as a default, most of the spending in China was occurring in the private sector, out of pocket, fee-for-services, under the table, all of that. So China has now a messier system than they used to 50 years ago. And that's very sad, even though they're spending 50 times more. And now the Chinese are now understanding this, and they are now committing to universal health coverage. And they are committing to almost doubling their public expenditure on this. My prediction is that that's going to fall short still. And that, and again, there will be still problems, but it's a great sign already that there's an assertion of direction for the Chinese. This is GDP growth over years. And as you can see, Sub-Saharan Africa has been growing faster than the world average and faster than the OECD countries, clearly. So Africa's GDP has been growing fast. So if we simply apply the projections from the regulations that we derived before, simplest projection speculation based on the World Bank expected, and actually is the IMF and also the projections for that Goldman Sachs and others have for GDP growth, we can predict that next decade, health spending will double or triple in many of the countries we are working with now. And again, it has been growing already. Population has been growing, and so that eats out. Uganda, for example, is a problem still. But health spending is going to be growing in these countries. And this is both a challenge, but I am an optimist. I see this as an incredible opportunity for health and for health system. Now, this is in the United States. This is projections by the Congressional Budget Office, which is a very authoritative, respected office in the US government Congress. And they show here that health spending today accounts for about 15–16% of the GDP. And before the century is over, it will consume half of the GDP of this country. Now, this is a projection of the Congressional Budget Office. It may be wrong, but this is what they are telling the Congress they see happening. This is amazing. And interestingly, it's not aging. We thought it was because people were getting old and the demand for services was growing. Aging is really a small slice of this growth. And Ambassador Tom Pickering recently with the Institute of Medicine report, when we discussed this, said, but how the hell are we going to afford to pay for that? And the answer is, it is because we will afford it that it will happen. In fact, it's because we've been affording it year after years that it's been growing. If you make $100,000 salary and pay $10,000 in health premiums, health insurance premiums, you wouldn't like to increase that to $30,000, right? Who would? Tripling of your health premiums. But if your salary goes up just by 50% to 150, the $30,000, still 20% versus 10% before, leaves you with $130,000 to spare, whereas before you had 90, even if you account for some inflation there. And this has been happening in America year after year, year after year. And instead of embracing the growth, we've been trying to fight the growth. And I will pose to you that that's actually the wrong way to address this economic transition. It was not aging. Actually, I was saying, many of you are familiar with this report, Bill Feige and others, looking at what matters in health. And access to health care really accounts for 10% of the gains in health. Most is the biology, behaviors, the environment. So how come, if this is the only tiny, if the health system and healthcare system accounts for such a small part of the health system, of the health standard population, how come we are spending more and more and more and more and more? And I actually kind of speculate that as burden of disease goes down, if we can assume that there will always be bugs changing and so on, but if by the end of this century we were to eliminate disease as we have known in history, health spending will not go down. And people are shifting from buying life, and of course there's still a lot of life to save, but there's a shift now from buying life to buying quality. And there is an insatiable appetite as economies develop, to buy wellness and quality of health. And so this is happening. One explanation, of course, is demand of the population in so many ways. But why does it happen this way is economist William Baumol from Princeton, who figured this out. And I'm a believer in his principles, but there are other economists who still challenge Baumol's tenets. But basically, Baumol says health spending increase is not the result of increasing demand for services or the increasing supply of expensive technologies. Everything matters, but they're small. The reason for increased spending is the differential in productivity across sectors in the economy. When other sectors in the economy, as we have been witnessing for most of the century, grow in productivity, whether it's in agriculture with 20-fold gains in productivity, and thus a commensurate reduction in price of food, whether it's in manufacturing, whether it is in distribution, in telecommunications, efficiency gains there means that the products and services will be cheaper. And by default, the inflation of the sectors that lag in productivity gain will be greater than average. And so sectors that cannot substitute labor, capital for labor, that is, that cannot be automated so that with money you can get things done without people doing the job, like health, where we want doctors and nurses, we don't want just a computer, although we believe in computers for health too. That condemns health, education, the performing arts to have inflation greater than average. And again, it seems that as GDP grows because of productivity gains, then you can expect to see a predictable increase in health spending for the foreseeable future in most countries. There has to be at some point some ending of this paradigm, but we have not seen it really in the last 50 years in this country, in most of the OECD countries, and we believe most of the developing countries will be having more of that. What that means is this phenomenon arises outside the health market. Traditional cost control does not decrease total spending. I mean, there's no country that I am aware that has been able to decrease total health spending as their GDP is growing. And actually, when you try to control costs out of policy, you end up distorting the system. And I think the United States is probably the best example of that. I will come back to that in a second. Now, this is a macroeconomist view of the world, in which, okay, richer countries spend more, and even more so than the GDP growth. In fact, that is the very definition of a luxury in economist term. That is, when your spending in something grows faster than your income, that's a luxury. But actually, at the micro level, in households, the opposite is true. Poorer households spend a greater proportion of their income in health than richer households. And so these two worlds coexist. They both coexist. They're both truth, and they've been studied extensively. And they collide. They collide particularly so when GDP grows. And so many of the countries that are now beginning to develop economically, there's been many. We talk about BRICS, but as I said, African countries are growing just as fast as many of those other countries from a smaller economy start point, but growing nonetheless just as fast. You create a collision in which as the governments, the countries get richer, but not everybody in the country gets richer. The poor people will be facing a growing inflation in health services. And you can predict a way, which WHO is now documenting, of catastrophic expenditure all over the world, particularly in those transitional economies. And this is predictable, unless there is social protection or insurance, which, as I said before, that's the problem we don't have for most of the poor countries we're talking about. And when we talk about universal insurance then, it's not about adding more money to then get it, but reorganizing what is now primitive out-of-pocket expenditure into more rational, prepaid risk pooling. And I understand Bob will tell you more about that tomorrow. The United States, I mentioned before, just as an example of this paradigm. In 1990, GDP, health spending, about 700 billion. Population, 14% without health insurance in America. We said then that we couldn't afford to cover the uninsured because health spending has been growing so much. We believe that there is a logical trade-off between coverage and cost, and that unless we control costs, we cannot afford to cover everybody. That's quite logical, but in my view of the world, it's actually a fallacy. Because what happens is health spending grows anyway, because GDP has been growing, even though policymakers have been trying. We invented managed care, we invented diagnostic-related groups for hospital compensation, we keep trying to decrease Medicare reimbursement for primary care every year, and health spending keeps growing as the GDP grows. And so we end up with a larger GDP in America in 2006, and a greater chunk of that going into health spending, so that we are spending three times as much as we were spending before. And now, the population which has grown, we have 16% of the Americans without insurance. So we're spending 3 times more, but we did not invest that growth in doing the right things. And by default, the money gets spent in all sorts of wrong things, from waste to really blown out profits, because how else can you have a new drug, good as they might be, Zerosime is one example, going for $500,000 a year. I mean, pricing is not the result of cost, it's the result of what the market can absorb. And this is an example from Seguro Popular Mexico, and our colleagues may expand on this. This is GDP versus total health spending in Mexico over the years. So this is a longitudinal example where the R-squares still hold high correlation, even in one country longitudinally. And this applies to almost all of the countries that we've been looking at. In 1994, Mexico had an economic crisis, and so we went through a somersault in GDP and in health spending, but then the economy recovered and growth continued, and health spending continued to grow with it. And this is when Julio Frank arrives in a new democratically elected government in Mexico in 2000. And of course, the normal response is, well, your spending has been increasing, we are cost out of control, same thing. And normally, the instruction of the Minister of Finance is you have to cap the cost, or maybe just allow for some inflation. Instead, the leadership of Julio, and I think it was very important in this, using evidence, but also ethical arguments, and the political space that democracy brought, convinced the government of Mexico to commit to cover the 40% of Mexicans who were poor, unemployed, or informally employed, who did not have any coverage, and to commit to cover them through this Seguro Popular, or popular health insurance. And in doing so, nonetheless, it was not something to be done overnight. It's not something that was very, very astute politically and managerially. It was something that was going to take place over a decade, really. And it will not going to take anything from anybody else. That is, the other budgets the sacred cows will not going to be touched. And so that, this spending has to be additional spending if he can figure it out. But of course, if you can read this data carefully, the future can be figured out. And so health spending went up, and 75% of the federal spending growth was for this new program in Mexico. And the important thing is that health spending has grown, but so has the GDP of Mexico. And actually, the health spending falls exactly on the line predicted by the GDP. And the question is, if Mexico had not committed to progressively extending universal coverage, maybe, I believe quite so, they would still have spent as much, but they would still have 40% of the people without insurance. And this is the paradigm that requires your thinking and research in your own countries, because it changes the argument as to how we're going to finance health in the future. Again, it will not be foreign aid. It's going to be domestic financing itself. Many policy implications. I would say, do not fight the transition. Embrace it. Simply trying to control costs will not happen. And this may be more relevant, of course, to those transitional economies. In many of the poorest countries, we still need to invest and help. Plan ahead, so plan for that future of growth and invest in equity and quality of the health system. Do get more bang for the buck. We know that performance matters and that more can be done with the same money. So as the money is growing, there will be more money for health, but we also need to get more health for the money. We need more research, no doubt. Clearly, this is an area, I don't want to convince you that it's an academic dream. We don't have enough publications to understand this, and education for our global health community and our national health communities. This is spending around the globe, as we discussed before, and this is the slice that goes into health systems, a small slice. Most of that, as we heard, is to train doctors and nurses, not to figure out the stewardship and the financing of your health system. And doctors and nurses matter, especially if you need them to provide antiretroviral treatment, but it's not the only part of the solution. And as you can see, in many of the countries that are here, they're spending, some of them more, in health systems. And as I said before, in some of those countries, things are beginning to happen. Rwanda is now increasing their spending as well. And Rwanda has been very good with their mutual systems to also leverage Global Fund to subsidize the premiums of the poor and those with HIV infection. So great experiences, I think, that we can hear more from Ghana and Rwanda in particular. Impressive how India, that is pretty much a private mess. Everything is 84% of the spending is private in India. And whereas in China, they can commit to universal coverage and you can expect that to happen. In India, it's more complicated. But they just got going with a commitment to universal coverage, and it's quite impressive how just in 1 year, they're just moving very fast. And part of that was the election. Hopefully now after the election, they will continue to commit to this social sector transformation. Very interesting. And back to the research part, we are investing little on health systems, the thinking, the capacity, but also the knowledge. In the United States, the world spends $150 billion in health research every year. 2/3 of that is American money. And in the US, this is the landscape. Pharma spends the most in R&D for products, pharmaceutical products. The NIH in biomedicine spends a lot of money too. And this is the American Agency for Health Research and Quality that is in charge of health systems research. Most Americans have never heard of if they have heard of the Global Fund, they have not heard of this agency. And maybe there's no word. They're spending $1 per capita in researching the health system that consumes $7,000 plus per capita. Clearly is the lowest investment in R&D of any enterprise that I know of, even as the money is growing so much. So it's good to hear that President Obama is committing now cost effectiveness. That will be part of the equation, but it's more than cost effectiveness, as you can see, that we need to mind this. So we need to increase that, and I'm happy to see that from the stimulus package, actually, this budget went up for health services, went up almost 3- or 4-fold, versus the NIH that went up just, still a lot of money, but only a third. So this needs to happen. There's been global attention. We are almost finished here. We started at the Rockefeller with a Pocantico meeting, just upstate with the state of the family, the Rockefeller family. And we posed the global challenge of health systems to a series of global leaders. And we started the conversation and getting it going. Lots has been happening. We have a commitment to health systems, to capacity, to stewardship, to the private sector awareness as part of the stewardship of governments. We also care for e-health, and we had a large series of conference. We see IT as the technology of health systems of the future that can help improve access, affordability, and quality of health services. And we've been supporting several processes and meetings, high-level meetings with the UN Secretary General. The first of that was in October 2007, where the Secretary General has committed to global health as one of the priorities for his administration. Follow up with a meeting with the President Jimmy Carter hosted in Atlanta with the elders and the Secretary General, where commitments were made to health systems, maternal mortality, and the most neglected diseases as the 3 areas that this new movement was going to support. And we just met yesterday at the UN, Michelle and many others, and this was now not a small meeting, but it was really the plenum of the UN with all of the delegations, ambassadors, so discussing global health, health systems, maternal health. And it's been incredible because we witnessed some of that in the AIDS movement, which was incredible on its own. Health systems we didn't expect to move up that fast at the highest levels of policy, in part because I'm worried that we haven't yet mobilized the whole community, and there's a lot of work to be done there, civil society and others to move. The G8 summit, we supported the technical working group, the TKEMI group on health systems that led to a declaration in the G8 of a balance between the priority programs and health systems going forward. And we're working with Italians to continue to advance this agenda. Next year, the G8 will be hosted by the Canadians, who do not need any advocacy in terms of health systems and universal coverage. And so lots of opportunity. The ministerial conference in Bamako, an opportunity to call for more research in this area, and there will be a symposium on research for universal coverage next year, global symposium. There's the report Institute of Medicine that also includes health systems now. This is the meetings we're referring to. There will be more follow-up in the economic, the ECOSOC group of the UN. We had a conversation with several stakeholders last month in the World Health Assembly on transforming health systems for universal health coverage. The G8 next year, WHO has decided the theme for the World Health Report will be universal health coverage. So clearly the discussion is now alive, but we still need a lot more research. We still need a lot more capacity. We need more resources for this to happen. And even though we believe it's more about reorganizing the financing of domestic resources as opposed to throwing in more aid, there's a cost in building the capacity and managing the change. And that cost is the responsibility of the international community. And it's a cost that we haven't yet costed, but it's something that out of this meeting, a process that maybe a global task force on universal health coverage will begin to address. So as a way of summarizing, total health spending is growing fast, driven by economic development during the last 20 years. This is a fact. In most low-income countries, this growth is happening in the private sector, and it is out of pocket, which is, as I said before, inefficient, regressive, accounts for 50 to 80% of the total health spending in Africa and Asia, compared to barely 10% in the richer countries. And it's leading to a wave of catastrophic expenditures that will only grow in the next decade. Without national stewardship, this will happen by default. We have a lot of mess happening around the world, unless we also have that rational stewardship and prepaid risk pool system, because otherwise financial risk will grow. This is the shift from saving life again to saving, buying wellness. Makes me think of the cartoon of is your life or your money, and health systems will increasingly be about quality and the money. The solution is less about additional ODA, and it's about reorganizing the financing and universal health coverage, which is about the health systems when it works. When the health system works, you have universal coverage, which is universal access to appropriate health services and affordability for the individuals in the system. And this is a challenge and opportunity that requires both greater leadership and capacity at the national level, but also international support. And I look forward to working with you in this space.
Thank you so much, Ariel. It's wonderful.
Thank you.
We have time. We thought we would just, take 10 minutes or so if there are questions in the audience about the talk. You're all hungry.
Yeah.
I have maybe a question / comment. I'm always fascinated by sort of the... Hey, my name's Anant from the Gates Foundation in Seattle, and I'm always fascinated by seeing the difference in the statistic you showed up, the $700 million we spend on health. It's now $2.1 trillion, and we claim to not be able to afford the uninsured. And in my mind, the question is not so much are we spending on those people. We are spending on those people. It's the question of how do we spend for everybody and for what services do we spend. And I wonder if there's an opportunity to shift and maybe it's already taking place in the vocabulary being used in the policy world, where it's not just about health insurance per se. Because by definition, insurance is about pooling resources to cover unwanted, unexpected events, not about getting the everyday vaccines, everyday well checks, et cetera. And so how do we as a community begin to shift the vocabulary needed to really have policymakers understand it's not about health care reform, it's about health reform?
Thanks. Good questions. The British don't like the word insurance. By the way, they always think it's American, private, and so I guess out of the World Health Assembly coined, and if you've been in some of those meetings, discussions on terminology and writing resolutions, when they came out with the wording of universal health coverage, it reflected a lot of those constraints and compromises. Although definitions are important, in the end is bringing education and clarity and then action. But I agree that you're also hinting at another point, which is that there are different segments of financing of health services. That is, it is not the same to provide the basic preventive interventions, which should be free for everybody, really, and point of service and does that. Is compare that with the space of risk of people who may or may not get a heart attack and may or may not get is the rare event, which is the insurance typically applies for. And there are others who then have chronic conditions, and they're now going to be having requirements of services going on forever. And then there's the end of life, which society can make many choices to what we cover and how we finance that. So each of those spaces are different, and different societies address them differently. Although, again, we have not been very explicit in the comparative systems analysis to see what is probably useful. In the end, there will be no cookie cutters, whether it is on the financing or on the service provision models, because there will be social preferences and resources and burden priorities and so on that will still have a lot of room for this. But I agree that there's no single space and the terminology may be confusing. The people speak of social health insurance, which is like more of the German model of employer-based premiums payments, or the British or Canadians, which are more tax-based systems, more general pools of resources. And so Medicare, for example, is not really a pool. It's like going in and out every year, right? So yeah, there are many models for the pooling, and I think tomorrow we'll hear more from Bob on financing pooling.
Thanks, Ariel. From your experience, especially in Mexico, what are we have to do for innovation in value? Or what are the opportunity areas in the Seguro Popular?
Oh, thanks. I mean, I could ask you the question, but we had an interest, and I think the Gates Foundation also, on the role of the private sector in health, both because of the magnitude and the neglect and the ideological sparks, but also because there's a lot of innovation taking place. And we have been landscaping around the world lots of innovations that the private sector is doing, even though they are profit-driven market mechanisms that provide services for the poor. And there's a lot of ideas from social franchising to vouchers to conditional cash transfers that Mexico has also led in, and that is being used in many other countries. Maternal mortality was discussed at the UN. And so if in India, for example, there's a new program, and you pay the mother to go and have the baby in the facility. And that gives the young mother leverage over the mother-in-law, who will say, hey, we have 12 and we're okay. Why do you have to go if most come out right? And so the fact that the service will be covered by a conditional transfer mechanism gives leverage to young wives, spouses, and so on to be able to. So there's a lot of those. And I think that cataloging that innovation is one thing that we need to do and share. We don't have a policy community to share this, and this is one of the things we are very much interested in. In a recent meeting where we heard the experience of Ghana, the experience of Thailand, and the experience of India, it's clear that there's a lot happening. It doesn't get published, and that's a problem. And that bringing together, and we're planning to do so next year, a major conference of experiences in universal coverage in low and middle income countries, because it is happening, and people are grasping with similar questions, even though the answers will be slightly different. And there's a lot to be learned by sharing. And so we are committed now to supporting that and to supporting the policy community space to have a place where you go for this. Because right now, and I was in WHO in the health systems group, and we were thin there too. There are budgets in WHO too within. Clearly a space where you can go and get all of this. It will be a useful thing, and so we'll be happy to follow up on that. And for you to share your own experiences.
Yeah, thank you very much for your interesting talk on, looking at the fact that health spending is increasing is reassuring in a way, but when you begin to look at who is benefiting from what, I mean, we've done some benefit incidence studies which shows that probably the top 2 richest quintiles are getting most of the benefit. And if you look at the financing incidence as well, I mean, there are several distortions which doesn't make it very progressive as we would desire for it to be. I mean, this is work that we're doing with South Africa and Tanzania, and I mean, surprisingly, across all the 3 countries, it's very regressive. And so yes, health spending is increasing, but as far as our health systems are concerned, access for the lowest 2 quintiles is still not, we're still not getting there. And for me, that is a bigger challenge than the fact that health financing is, I mean, more money is being spent. How do we make it more equitable? For me, that is a challenge.
Right, John. I think they're actually linked, as the experience in Mexico shows. There's the political dimension of the country, of course, and so that trying to redistribute resources is just a tough thing to do. There's real power in the systems and so on. But if instead you will simply were to invest that future growth in health spending in the country, as Mexico did, then you have an opportunity. So it becomes an opportunity for visionaries championing with clever salesmanship, really, of not taking away from the current people who are getting money to invest the future growth in health spending into equity and quality. And that is what the opportunity of this economic transition lays for us, to be aware, to educate our prime ministers. It's often not only the Minister of Health, it's the President or the Minister of Labor or the Minister of Finance, and having this understanding becomes important. So again, researching this transition in your countries, making that evidence available to the key decision makers, and positioning, as in the case of Ghana, there's already commitment to increase insurance, of course, universally, and it's just, it's tough to keep going. And there will always have to be some room for the politics. That is, some people will be able to afford things outside the system, but as we said before, there's no outside the system. So some people spend a lot more, even if it's their own money, the rich people, they're still eating into the pie of the health spending for the country. Same thing could be on medical tourism in Thailand and so on. And so I think that there will have to be some room, some accommodation for that political pressure. And how this is done in every country, well, it will depend on the politics and the leadership of each country. Some countries are simply committed to full equity, right? And there are some who are doing quite well. There's Cuba doing quite well with their financing model and the provision model. Thailand has been able to do it with a great commitment to equity. There's room for some of the richer people to go to the private hospital. So how much of that is okay as a compromise? Well, those are good questions.
I think we have time for one more question.
Please.
Yes, you just mentioned the increase in health spending in relationship to the GDP, but it did not look at also the disease trend over time, especially considering the emergence of new diseases and the cost it will take for intervention. Then it also did not look at efforts that are being made also to improve healthcare and provide equity by investing resources to reach the very poor. Take, for instance, immunization. Like in my country, for example, to move from about 35% DPT-3 coverage to about 85% meant investing more and to be able to reach very hard to reach areas and provide these services free. And that brings it back to the question that the concern Ghana had about reaching the lower quintile with services.
Yes, and I obviously agree fully with that. We didn't go into that, but is fully agree with that. Yes, we would like to say that, yes, there will always be emerging diseases, and clearly AIDS is the elephant in the room as to how things can happen and require attention and priority, and that is something that can always happen in the future. It's just that as a whole, as I said before, as a whole, the burden of disease is declining in the world, and which is good, but health spending is not going down, and that's the principle I wanted to highlight. Equity, agree, but you also hinted at the point of priorities. Relate to both the global health initiatives and the fact that governments may have priorities. Priority setting is a function of the health system stewardship, and so it's a good thing. To the extent, in fact, AIDS treatment programs were addressing neglected priorities and burden in countries, it's probably a good thing too. And to the extent that they are after a disease that can be eradicated, it's a worthy investment in the long term. To the extent you bring best science, best practice, and monitoring capacity, that also brings strengthening. There's also a lot of good things that some priorities can do for health in the context of a rational health system. So it should not be at the exclusion of such approaches. It's just that each of those approaches should be always reasoned within the context of your larger health financing. And again, for equity, that growth in health spending is, in my mind, the best opportunity that we have in the developing world to address the needs of the poor.